everybody. I'm presenting on my QI thing.
Sorry, who are you?
I'm Dr. Kiyosaki.
Do you have any financial responsibility?
I have no disclosure.
No.
Somebody offered me to get a report.
All right.
Are you a resident here? You're a medical student.
Michelle Chen. My name is Michelle Chen.
All right, we'll do it.
Okay, so I did a
Hi, Dr. Jackson. How are you?
Wiki consult. It was created by the Dooming Chief Consult, spearheaded by one of the medicine chiefs. And the idea behind it is to streamline the consult process and improve inter-service relations and communication. So they propose that each specialty would choose 3 topics, but really the council came up with 3 suggested topics, and they said that you could either follow those or go off on your own. And give a brief overview of how they frame the problem and important information to gather and possible initial management strategies. For things, common things like MIs or capacity for psychiatry, things like that. So they opened it up to all of the subspecialties in the hospital, and so far 14 specialties have participated, with the ones listed above. Some of them are more helpful than others, like orthopedic surgery, for instance. They covered compartment syndrome, and they have one bullet point that says this is a clinical diagnosis. So that's real helpful. We were suggested epistaxis, peritonsillar abscess, and dysphagia, but I changed it to hoarseness. Both dysphagia and hoarseness I felt were like equally large beasts to tackle, but I feel like we have a lot of hoarseness consults and people don't have a full understanding of what exactly we do. So I completed the consult section, and then I went over it in detail with Dr. Lee, so that there would be somebody from our department, at least at attending level, looking it over before it's published publicly. So one of them was the nosebleeds. And basically, we just went over the important points of history, the important points of exam and labs together. And then we gave them a brief outline of how to manage acutely, then what strategies to prevent. And then we also talked about when we pack and when we cauterize, because people often think that we just jump right to packing or jump right to cauterizing. And we also kind of detailed briefly the different kinds of packing we use, and which ones are absorbable, which are not, and what they can expect and what they should be removable. So right now, Access is currently a Google document, so it's open. So this is an example of it, and you basically click on the side, and it's kind of like an outline. And this is like the otolaryngology portion of it. And what we're trying to do is get it a button Epic, and it's going to be hidden in one of these other buttons. So when you choose the Epic tab, and then you hit web links, and there's all these other things that are there. I don't know if you guys have used this before. I know I've used like the antibiotics one on here before, but hopefully we'll get the Wiki consult that comes up somewhere right above duodenoscopy.
So part of my quality improvement project is trying to decrease the cost of portable laryngoscopy for inpatient consultation by improving the workflow in which we obtain and use our scopes here at Stanford. I'll start with just a story. Last Saturday, one of our residents, Pico Corazon, called. She received 4 consults within the first couple of hours of being on call. 3 of which needed fiber optic laryngoscopy in the hospital. She went down to the central supply distribution, and there were no scopes available for her at the time. It's quoted that we have 6 scopes available usually at any time for our inpatient consults, but it's far too frequent that we as residents get down there and find that there are no scopes available and have to wait greater than 30 minutes for the scopes to be processed and everything. So the goal here was to improve our workflow so that we don't have that wait time, don't have the lapse in care, especially for emergent cases like airways. So Central Supply here at Stanford basically is the group that controls organization and workflow for distributing the scopes. They recently changed their location and also their workflow. Right now, you obtain the scopes from Central Supply down in the basement, and then you drop the scopes off in the dirty supply room on the floor in which you've used the scopes, which sometimes leads to a lapse in return of the scopes. 6 scopes are available, they say, but it's very rare that you'll have all 6 there. Usually I've only found about 3 there at a time. There's no way currently to track the scope's location to improve efficiency, and there's a significant burden to resident workflow because of this. Another issue is that when scopes get lost, they get damaged, and so the cost of repair for scopes has been very taxing on the department. So with regard to resident workflow, I just wanted to get a sense from the residents what the issues were, and so I surveyed the residents, 12 of which responded. With regard to how frequently scopes are used, residents said about 50% of them use them occasionally, so that's about 30 to 68% of the time. Yeah.
I wear the PTY5 in that cloud.
They actually never responded.
Continue.
Question withdrawn.
Oh, done.
Identify them.
So of the 12 residents, about half of them also said the scopes are absent about 30 to 60% of the time. Which, you can imagine you're running to an airway. You won't want to make sure that you have the ability to pick up the scope on the way there. Most of them said, or pretty much all the residents said, that if there is an emergent airway that they would have to pick up, that they would have to get a scope for, they would go down to Central Supply themselves rather than having the scopes delivered. So that would take another 10 to 15 minutes, or sometimes 10 to 20 minutes added to the console. And then about 67% reported that the scope is, that the portable scope that we have with just the handheld light is usually not available. Most of the time we have to carry the scope with the cord and this huge cart that we have to like move through the hospital and take up the elevator and stuff. And it's just kind of a bear. And unanimously, they believe that the stroke distribution system and workflows have a negative impact on patient care. That should be. And 92% said the patient tracking system would be beneficial for these scopes. I forgot to also mention that when there are no scopes available, cleaning over turnover time is greater than 30 minutes for 50% of our residents. And then I asked kind of the residents what their thought on the economic burden of scope cleaning and replacement would theoretically be in their mind. And most people think that it probably lies around $20,000, $30,000. So I actually contacted Central Supply. I got a list of the repair costs associated with our laryngoscopes. And a lot of times there are issues with the fiber optic scope because there's damage at the tip or there's a valve that's not correctly placed. And so the cost of over the 2015 year was about $22,000 just for repair. That's not including the number of new scopes that we had to buy to replace the old scopes that had broken beyond repair, which is pretty significant. So what I wanted to figure out was whether or not we could find a way to improve scope utilization in the Stanford inpatient setting, to decrease the cost of repair and replacement, and also to decrease the resident work burden. So I came up with this idea of using the Tile app, and I don't know if you guys have heard of this. The Tile is basically a small, it's basically, Ryan has one of his keys. I'm passing around a little demo here. It's a small tile that can be attached to something that you use frequently or it gets misplaced frequently. It can be paired with an iPhone, and that iPhone can track using GPS and also using a locator, and some type of like a sound identifier or alert where the lost item is. So let's say someone gets scoped on C2, and a patient gets discharged, and the scope ends up in the dirty supply room, and you're on C2 and you have to call for another consult, and there are no scopes available down in Central Supply. You can look for your scope using your iPhone app, press find, and the scope will alert. It will make a sound or a ring. So you can find that, send it back, and have it processed.
Wait.
So the ringing basically allows you to ring the tile itself, and then you can use GPS to also kind of locate where the scope is.
What does that sound like?
Like this.
What did you say, like Stanford Hospital, or because like,
Yeah.
what if it's like
No,
C2 or?
so it actually does a pretty good job of locating where within Stanford Hospital where it is. It's not perfect, and obviously you can't distinguish floors, but you can tell whether or not it's in the C2, B2 area, or if it's like in Central Supply being cleaned or not being cleaned, or if it's somewhere in the Pete's Hospital. So it certainly distinguishes. It's not perfect. I think they would need a better system, just maybe exclusive to Stanford, to get perfect kind of like geolocation. But right now, I think it's a good working fit. So right now, it's 3 of our scopes in Central Supply have been outfitted with tiles. The light tower has also been outfitted with tile, and the scope in the ER has a tile as well. If you download the scope app, not only are you able to locate not only is the person who has the scope app and the tile linked to it able to locate the tile, but the other people that have the tile app are able to use, I guess they're part of this community that's able to help identify scopes if it's picked up. So, the more people that have the tile app, the better, because it'll kind of help improve it'll help to better improve our ability to find scopes. I've run into one major roadblock, unfortunately, is that the tile app limits the number of people you can share each tile with. So they're going to implement different software upgrades soon that allows you to share it with as many people as you want, but right now we're kind of limited in terms of the number that can kind of see the tile, so that's my.
Right, but Brandon, if all the scopes are being cleaned, which is very common, right? Is there any safe way that a scope that hasn't been cleaned yet can be sheathed and be used in an emergency on a patient?
They don't allow us to
Yeah.
shift anymore.
No more sheaths?
No, it's
Oh,
not.
man.
Do they have to be taken off when they're cleaned, or are they?
No, so I did a little test test with the turnover cleaning, called cleaning cycle. They're water resistant, they stand up pretty well to water, so. Water resistant. Dr. Williams.
Yeah.
The question?
So what's the workflow in terms of after scoping somebody?
after
What happens usually?
Unfortunately, yeah. So previously, after patients are scoped, we would be able to take the scope down to central supply and give it to the central supply people to take to the dirty room to clean. They've changed it as of last spring, in that we now have to drop it off in the dirty supply room on the floor in which we scope the patient. Then we have to call general services to come and pick up the scope from the dirty supply room. The general services takes probably about an hour to an hour and a half to actually get the scope and return it to central supply. And then the scope has to be processed at the time that it reaches central supply, which usually is delayed another 30 minutes to an hour. So turnover time for the scopes has increased from probably about an hour when we were able to return it ourselves to more than 4 hours.
So why?
I still return it myself.
Yeah, what happens
Yeah.
if you return it?
So I actually had an email from one of the central supply people saying that there was an incorrect returning or incorrect processing of the scopes.
What does that mean?
JCO basically came in and said that because the scopes are dirty, you can't bring them back to a place where you have clean scopes.
So
They
can
want
we take
to
it ourselves
separate-
to the dirty place?
Potentially, they said that you're supposed to keep it in the sterile, what's called the central supply. Dirty
But the
supply.
transport people move like molasses.
Yeah, they do. And that's a major issue. And hopefully with this tracking system, we'll be able to figure out. where
See
the
how
problem-
slow they are.
Yeah, see how slow they are and bring it up to the administration. So.
Another thing that's happened, I know I'm probably part of the problem, is that I've gone to see consults or scoped, one of my patients on the floor, and then the scope just sits in the room. And nobody takes it for days. I've seen,
And that's
See the
another thing
scopes
that this would
sitting in the
hopefully
room.
help out with, maybe the injury
maybe,
patterns.
the team
Yeah, did you want to
rounds,
scope them again?
the team rounds and the scope is,
Sometimes the
nobody
patient
sends it back.
Get discharged and the scope will stay in the room. Until a new patient shows up in the room.
Right. So, I mean, if you guys see a scope
Keep bringing
on
it.
rounds, probably shouldn't be sitting there.
Yeah, the only time I feel like that happens is when we're doing serial scope exams, like scoping someone every morning. But maybe not.
Download the title app.
Part of my research plan is to like try to figure out what I want to do in my life, so I'm a little philosophical. And instead of talking about my research, talk a little bit about sort of my goals. So just in general, like I feel like I am really interested in how organizations work, and prior to residency, I spent a lot of time like figuring out how to buy and sell companies, and a lot of that is figuring out how companies interact with each other, how they figure out like what projects they want to invest in, what the growth curve of their product is, and really digging into both the management philosophy as well as the interactions of within the company and also across companies. And then I'm also sort of interested in looking at how populations work and interact, and can we quantify that somehow through a statistical model. And more broadly, I think it's interesting if this could all be couched in something where you're actually doing something to improve things. And then I have a lot of uncertainty in general. So these are sort of things that I thought about going into my research block. And I was really interested in health services research because I felt like, this is a way to look at how organizations interact and how you use the provision of services to influence outcomes, and can we improve delivery, can we improve the organization of healthcare in order to improve outcomes, or does it affect outcomes at all, or maybe it doesn't, maybe delivery and organization does not affect our cancer care or healthcare outcomes. So that's sort of where all the
those are, I think, so I think the goals are, of my block are to do some research, but also just like, you know, try to figure out these larger questions and, you know, have the time to meet with different people, maybe audit some classes. And so these are sort of a few of the projects I was thinking about for my block, and I'm gonna talk about the first one because it was the most fleshed out, where I'm looking at sex-associated variation, head and neck squamous cell carcinoma, particularly HPV positive squamous cell carcinoma. So just very briefly going to this, you know, there's over 59,000, over 12,000 incident cases, over 12,000 deaths distributed head and neck, and the majority of these are in male patients. And originally this was like the traditional white male smoker, you know, that would, but more recently there's been an increase in incidence of HPV-associated head and neck cancer non-smokers, but we still see the trend where there's a larger proportion of cases in males relative to females. And there's some preliminary sort of biologic studies that showed a hormonal or immunologic etiology for this difference, but those have been sort of on a very limited number of patients. And then in lung cancer, there's been an increase, in lung cancer in non-smokers, and research in that has actually shown that there have been sex-associated differences in treatment as well as cancer outcomes. And then, you know, one thing is that not only does sort of gender play into sort of the biologics of the cancer, but potentially there's a difference in access. So in head and neck cancer, we've actually shown that female patients are less likely to receive guideline-directed adjuvant therapy. And so perhaps some of these differences in head and neck cancer is not only due to the link to the incidence and the pathology, but also due to access, and that can affect survival and prognosis. So the goals of this project are really to look at sex-associated variation in the clinical and pathologic characteristics, as well as survival in HPV-positive head and neck cancer, treatment type and access, and then also look at any variation, pathologic and radiographic extracapital extension. So just going briefly, I'm just going to focus on these two aims now. So aim one is to look at, on a broad scale, is there a difference between male and female patients with HPV-positive oropharyngeal cancer in terms of their clinical and pathologic characteristics? For example, are they more likely to have extracapital extension or N2B and 2C disease? And then I also was curious in whether there were any sex-associated differences in overall survival in the patients who did receive adjuvant radiation therapy or adjuvant chemotherapy. And then the second aim is sort of more of an access question, where I was curious because in head and neck cancer globally and in a lot of other neurosurgery and lung cancer, they've shown that there are disparities where female patients are less likely to get recommended adjuvant therapy, less likely to sort of follow through with recommended treatment in a timely fashion. And so are there any sex-associated disparities in treatment type and access in terms of time to treatment between male and female patients with HPV-positive head and neck cancer? So this will be a retrospective review of the population level cohort. We use the National Cancer Database, which covers over 70% of incident cases of cancer in the US. And so sort of our preliminary review, I have about over 8,000 patients with HPV-positive head and neck squamous cell, about 89% are based in the oropharyngeal subsite. And so in terms of my independent variables, I'm going to look at demographic, clinical, and pathologic variables. Particularly, I'm curious at looking at the way extracapital extension and global disease varies with gender, as well as, and my primary, and also looking at whether there is a difference in overall survival, and also in terms of my access question, time to treatment. So time to initial surgical resection, as well as time to adjuvant therapy. Especially since there has been a lot of recent interest in looking at using time to treatment as a quality metric. And just in terms of my statistical analysis, I'll be looking at survival analysis and univariate, multivariate regressions. So I think in terms In terms of limitations, I think I don't have data on disease-specific survival, so it's only overall survival, and I don't have data on recurrence or reoperation. Unfortunately, I don't have any smoking data, and there isn't a, this is all based on sort of what the registrars have extracted from pathology reports in terms of extracapillary extension or middle of disease. So there's a lack of centralized review by a head and neck pathologist. And then, so very briefly, my last aim was just to look at the differences in pathologic and radiographic ECG between male and female patients with HPV positive colorectal cancer. And this is sort of very preliminary. I've talked to Dr. Fishstein doing a retrospective chart review based on her current ongoing study where she's looking at patients with pathologic and radiographic ECG and looking to see if there's sex-associated difference. And I would predict that, based on our preliminary ECG data, that males would have both more likely to have pathologic ECG and radiographic ECG than female patients, voting for other demographic and clinical characteristics. So that's it. And
this is my quality improvement project for the year, and what we're trying to do, as Dr. Seidel and myself, is to track post-tonsillectomy outcomes on the pediatric side. So as we all know, some complications of tonsillectomy include bleeding, pain, nausea, vomiting, dehydration, infection, and the list goes on and on and on and on. And this is actually a study that came out this year. It looked at a California discharge database from 2009 to 2011. In total, there were over 35,000 tonsillectomies and almost 5,000 revisits within 30 days, either to the emergency department, an inpatient unit, or an ambulatory surgery center. And the majority of these were for dehydration, nausea, and vomiting, and then 18% for uncontrolled pain, 14% for throat infection or fever, and then actually 29% for bleeding. The overall revisit rate was 10.5%, and 2.1% of the patients were readmitted. The readmission rate specifically for bleeding was just over 11%. So these are the clinical practice guidelines for pediatric tonsillectomy that came out in 2011 from the Academy. And their statement essentially says that anyone who performs a tonsillectomy should be keeping track of their rates of primary and secondary hemorrhage at least annually. So to that end, my specific QI objectives were to establish a method for tracking our total number of tonsillectomies and the outcomes thereof, and then to streamline future QI presentations. So now I know, every couple months we have a presentation about a post-tonsillectomy hemorrhage, and it would be great if at the beginning of every month we could just take 2 minutes to say, okay, this is the number of tonsillectomies we did this month. There were this many bleeds, this many readmissions, and then have that be our method of presenting this data. And then, as mentioned before, these are technically guidelines put out by the Academy, so everyone loves rule followers, and I'm just making sure we're following rules. So this is our post-op call phone template, and this is in effect in Epic already. I know some of the residents, or most of the residents know about this. It's essentially the same way that you would document a normal telephone call, except now there's a drop-down menu wherein you can choose the physician that did the surgery, and then you can choose the method that the tonsillectomy was performed with, and then whether or not the child came back to the clinic or the ER, and then, clicking each box essentially leads you to another drop-down menu. So it's pretty easy. You just get to click through all these things instead of writing your usual note of, mom called after tonsillectomy and patient's having pain, etc. So this is what it looks like, and then there is a form at the end for free text if you need to do that. So this is data that I just pulled from the last month of May for our post-tonsillectomy outcomes, and this is the Excel sheet that it spits out. So essentially that shows that we did 47 tonsillectomies on the ped side in May. There was one visit to an outside ED on post-op day 6 that was related to pain, but no readmissions or operations. And as you can see, there are still a lot of blanks, so we actually only had just over 40% of in the future, I think number one would be to increase use and compliance of post-op phone call templates. I know that the residents are hopefully using this now, and so it's mostly going to be a matter of contacting the people that want support and Welch that are responsible for post-op phone calls. And then eventually, when we have enough data, ideally we can have an institutional database that people could perform studies with in the future based on our data collection. That's it. Any questions? Yes, Dr. Tron.
Okay, 2 questions. So how do you capture those who went to outside ERs? Is it from this, so everyone's gonna get a call? Is that what you're saying?
Everyone gets a call post-op.
Is it 14 days post-op? Or what
It
day?
varies. So
Because right now they're only calling like post-op day 2. So you may not catch those.
yeah, exactly. So right now they are calling usually within the first week. So I have to meet with them. I try to meet with them next month to kind of rearrange the schedule for calling, and then also just the whole process of documenting the phone calls.
Because they're calling just to see if they need any help. But if we're calling to see if they actually went to an ER, I think it would be more useful, like at 14 days.
Yeah.
And the next thing was that first paper that you showed was from 09 to 11.
Right.
And that was really before, that was when everyone was using Tylenol and codeine. So in terms of nausea, vomiting, dehydration, it'd be interesting to know if there's a change when, Tylenol and Motrin was instituted more broadly.
That's true.
How are you extracting the data?
So the pediatric EPIC actually has a method by which you can go in and generate your own reports. I don't know if that report is just shared with me specifically since I've been working with the EPIC people to put in these templates, but it's a relatively easy thing to go through the main EPIC menu and go to my reports and then generate this report.
Probably from IT, do all patients come back for a clinic post-op, or some of the follow-ups also by phone?
Attending specific. So I see all my consults post-op, but Anna does not. Neither does Kay. Like, you know what I mean? Like, everyone has a different formula.
Yeah. I mean, I wonder if some of this could be blended in with, for our hospital, their routine consultations get phone follow-up only on a scheduled basis at about the 1 month mark by our NP with a template. And in part, we're going to ask things like, were you admitted and did you have any bleeding? But in part, we're also asking, and how's the snoring? And how's the voice? And at the end of the phone call, and that's all documented, is, and would you like to come back in for a face-to-face? And then most families say, no, we're happy, everything's great, and then we avoid that visit. And families sometimes really like that, rather than taking a kid out of school, taking time off, or coming and waiting in the waiting room, all of that. But if you're going to be making these phone calls, you could think about piggybacking some of that work.
Then that phone call would have to be at a month.
Yes.
Yeah.
Yes, that's why we make it at a month, is because
Yeah.
we're going to catch all your post-op problems, and hopefully we're going to be able to determine that your presenting problem is improved enough that we don't need to see you again. And it's not every kid. The kid with a bad sleep study, or you've done something out of the ordinary, of course you're going to see them back.
There is a lot of work to do in terms of our current algorithm of following these patients post-operatively, because there is a wide attending variety in terms of who gets called, when they get called, if they get seen. And then just a matter of reaching the patients is sometimes difficult as well. Some patients just never call back.
That's right. And then they show up.
So in terms of bleed rate, we don't necessarily catch bleeds elsewhere. Sometimes we catch them on phone calls, sometimes we don't. But we do track our bleed rate every 6 months and then annually. And we do it by pulling reports out of EPIC for was this kid readmitted? Did this kid go back to the operating room? Even though we think we're reporting that on our M&M on a routine basis, we'll always catch a couple others that never got the form filled out.
Yeah.
Just by our secretary going through and figuring out who came back in for whatever reason. especially who came for admission or OR.
And do you know if that's based on, do you have a list of patients that have undergone tonsillectomy?
Yeah, so we keep a database of cases done, and so you can sort it by CPT code, and we then sort it by all and PD and adult. And so we have a reasonable grasp